Wonderful to see so many people. I am so excited to be here to chair the next session. And one of the reasons why I'm so excited is I was involved in some very early planning work for womenmind. And I remember one meeting, Deborah Gillis, you were there, Vicky Sturgiopoulos was there, and we talked about what this whole womenmind thing might look like. And one of those elements was a conference like this, which seemed like a pie in the sky concept. And here it is. I can't believe how many people are here and how many people are in this room. I'm so thrilled. And congratulations, Lisa. Congratulations, Jenna, for making this all happen. I am just honored. I'm so honored to be here. So we have a really exciting session, and I'm like really thrilled myself to chair this session because it's so meaningful to me, the work that's being done with people with lived and living experiences. So the topic of this session is elevating voices, integrating expertise and advocacy and collaborative research for gender impact. So exciting. So I am going to move things along real quickly. I'm so excited that Sophie Soklaridis and Holly Harris from CAMH, please come on up to give a talk. And I'm so excited about this on co-design and research involving patients and family. Here you go, Sophie and Holly.
So good morning, everyone. It's so delightful to be here with all of you. And I actually can't believe how many people are here and how many people are here virtually too. It's really a testament to, what happens when funding gets put into these important initiatives. So I'll just quickly introduce myself and then Holly will introduce herself. I am Sophie Soklaridis. I'm a senior scientist and scientific director at the Center for Addiction and Mental Health. And I'm also the inaugural research chair of recovery and equity focused mental health education research. So again, an honor to be here. Holly, do you want to introduce yourself?
Yes. Hi, everyone. My name is Holly Harris. I use she, her pronouns, and I'm a research professional specializing in co-production and participatory action research. I currently work as a research coordinator for Recovery College Research at CAMH, and I'm also pursuing a PhD in gender, feminist, and women's studies. I also identify as a person with lived experience. I identify as neurodivergent, and I've been a consumer of the psychiatric system for most of my life. And these lived experiences shape, guide, and inform my work.
So Holly and I today are going to be storytellers, and we have 20 minutes. And so short story, but we wanted to share with you how we got involved in this work and how our thinking has evolved around inclusive leadership and co-production. So without further ado. So on Saturday, April 7th, 2018, the day before Easter, I received an email from Dr. Catherine Zahn. Now, Dr. Zahn at the time was actually my boss's boss, so was my boss. Anyway. But she was also the president and CEO of the Center for Addiction and Mental Health. And Dr. Zahn's email was significant, not only because it was sent on a Saturday of a holiday weekend, but also because it would end up putting me in the middle of a heated correspondence between two opposing and powerful leaders. The body of the email simply said, "Sophie, what do you think?" with an article attached. This article was written by a female physician who at that time was worried about how the Me Too movement would impact the availability of male mentorship. So I read this article and I found this article deeply disturbing. The author in this case was asking male mentors to please continue their mentorship of women, even though the Me Too movement was making that relationship more challenging. So if you give me a moment, I have to admit this article still makes me Ooh, okay. There was this possibility when we were talking about the Me Too movement that women's voices could actually be heard. And articles like this one were once again putting other priorities first. So I shared my opinion of the article with Dr. Zahn and provided some light feminist theory to explain why I felt the way I did. And then the next thing I knew, I was copied on an email to the chair of our psychiatry department who happened to love the article. And in her email to the chair, my CEO wrote that she was offended by this article, but was having a hard time finding the words to articulate how she felt. And so in response to that, she enlisted me to help her with the vocabulary to express why she found this article particularly disturbing and distressing. And then I watched the flurry of emails go back and forth, collegially, of course. But these were two very strong leaders, and they had opposing opinions. And so I remained silent during this debate. But what this debate did was make me think more deeply about the topic. And so I emailed Dr. Zahn and I shared with her some of my preliminary thoughts. And I asked her if she would like to co-write a commentary as a means of adding to the conversation. And she agreed. And when I told her I wanted us to submit to the New England Journal of Medicine, she surprisingly didn't bat an eye. And all she said was, sure, go for it. Apart from just working with Dr. Zahn on this, I invited some other powerful women to speak on the subject. Dr. Cynthia Whitehead, Ayelet Cooper, Valerie Taylor, and Deborah Gillis. These co-authors were incredible and supportive, but one of the most amazing things they did was make space for me to have a voice. So in 2018, I was not an established leader, and this was, and sadly still is, a provocative topic. And these powerful women leaders let me bring my voice to the subject and protected me from the most egregious attacks over the topic when it was published. And it was really through my experience with these leaders where I learned something very compelling about the practice of inclusive leadership, not the least of which is that it is a practice. The practice in this case was providing space for someone like me to write about a dangerous topic and publish it in a major journal, knowing for certain there would be blowback. This leadership practice meant that they would have to be part of that blowback. They'd have to stay involved and shield me from it. I will say again, I was not a leader at this time, which meant they would be seen as more accountable for the choices we made than I would. While everyone involved had more to lose than me. Oh my goodness. Is anyone asleep? Because if they were, they're not anymore. Dr. Zahn, as the CEO of the largest mental health hospital in North America, was in a specific position. Her actions were highly visible. Given the nature of the topic, we knew she would receive media attention. She was put in a position whereby she was asked about her own Me Too experiences, and her responses were broadcasted widely and publicly. Dr. Zahn and my other co-authors chose to shield me. We could do this work because this group of leaders allowed me to remain safe. As inclusive leaders, they treated me as an equal member, and allowed my voice to be our voice. And in exchange, I was empowered to lead us towards the publication of a controversial article in the New England Journal of Medicine. And this experience helped me see the kind of leader that I want to be. So when I was named the lead scientist on a grant that required patients to be equitably involved in the research process, I knew this was my opportunity to engage in this practice. And today we are highlighting this project because we are so proud of it, and because it's a perfect example of what becomes possible when partnering equitably and co-producing mental health education and research through inclusive leadership. So Holly was the principal knowledge user on this grant, and I'm going to hand it over to her now to discuss the transformative value of co-production using our Recovery College research project as a case example.
Thank you, Sophie. I'm always so moved by that talk, and I'm really excited to share a little bit about our project today. So in 2019, I was working at another academic mental health hospital. My supervisor at the time came to me and said that she had a colleague from CAMH who was looking for a principal knowledge user, a person with lived experience, to partner on a grant focused on Recovery College research. For those of you who aren't familiar, Recovery colleges are low barrier, mental health and well-being oriented education programs rooted in the principles of co-production and peer support. And in the context of mental health programming, education, and research, co-production involves people with lived expertise of accessing health services, or in other words, patients, people with learned expertise from profession or academia, and people with both of these perspectives collaborating to design and deliver services and initiatives. At the time, I'd been working as a lived experience co-investigator on a research project focused on the personal recovery phenomenon, and I'd been facilitating in recovery colleges for a couple of years at that point. The project seemed very aligned with my values, my interests, and seemed like a wonderful opportunity to collaborate. But above all else, it seemed like a perfect opportunity to continue to leverage my own lived experiences as a source of strength, resilience, and expertise to maximize the voices of those with lived experience who have been historically excluded from mental health research spaces. And after speaking with Sophie, I knew that our values were aligned. As is common in mental health research, Sophie could have engaged me as a principal knowledge user in a consultation capacity. She could have brought me on to a predetermined agenda and gave me very specific tasks, but she didn't. She considered me her equal partner, which gave me the opportunity to grow, lead, plan, take risks, and get creative. And what we found was that inclusive leadership is contagious. We extended this beyond our relationship as co-leads and fostered these relationships with all of our team members. As leaders, we saw our role as creating spaces where everyone could teach, learn, and lead in their own way, and co-create new knowledge and realize new possibilities at the intersections of all of our unique perspectives. So we submitted our grant application and we got it. So this project aimed to bring together people with lived experiences, researchers, and scientists to explore how recovery colleges were evaluated, whether or not these evaluations were co-produced, and how those who were most impacted by the programming thought they should be evaluated. We wanted their metrics of success to drive what we were evaluating. And given that co-production is central to recovery colleges, we believe that these values should be upheld in recovery college research. Everything that we did was co-produced. We assembled our team of people with diverse lived and learned expertise who collaborated on the proposal. We co-created and collaboratively carried out a scoping review process, a qualitative interview process. We co-analyzed the data. We co-wrote manuscripts and collaboratively developed presentations, including this one. We often get asked how we do co-production. Rather than a destination or something you do, co-production is an approach. It's something you embody and an ongoing commitment to learning and power sharing. It requires trust and time to grapple with differing opinions and the space and flexibility to do things differently. If we were asked if co-production is worth it, we may shamelessly brag about all of our academic achievements. So we published 7 papers instead of the 2 that we promised to our funder, one of which was published in the Lancet, which is a very prestigious journal, if you don't know, and one of which was accepted without revisions, which never happens. We presented at many local, national, and international conferences with awards for our presentations, and we would share that recently we've been awarded a federal knowledge translation grant to co-produce and pilot national metrics for recovery colleges to help us progress the national recovery college movement and advocate for the funding and sustainability of these programs. This has never been done in the history of the recovery college movement. We are at the forefront of this movement, and we have people with diverse forms of expertise at the forefront. But we would also highlight that through co-production, you don't only get products and outputs, but a rich process that is teeming with learnings. You learn so much about the people you work with, yourself, and the work you're doing together. You find shared energy and passion and motivation. And with co-production comes the opportunity to see things, see new ways of doing things that aren't visible when working within the status quo. So consistently, through our reflexive practice, our team identified 4 key values that we embodied through our collaborative process. The first is that of power sharing. In contrast to traditional power structures, our team embodied distributive leadership approaches, which translated into shared decision-making and shared accountability. The second is a practice that we call multi-directional learning, which involved each of our team members simultaneously assuming the role of teacher and learner and co-creating new knowledge at the intersection of our diverse perspectives through the process. The third, entitled Connection Through Vulnerability, there's this idea that vulnerability is contradictory or inappropriate to professionalism, that in order to be taken seriously, we must leave parts of ourselves at the proverbial or literal door. Co-production, through its emphasis on challenging traditional power dynamics and centering lived experience, asks and arguably requires the willingness to put our professional hats aside and share from a place of vulnerability and authenticity as people first. This would not have been possible without trust. And the last value is one we refer to as the slow and steady wins the race value. As opposed to traditional approaches that prioritize rigid timelines, we quickly learned that in order to meaningfully collaborate, we had to embrace flexibility. And we did this in 2 ways, through pace and space. First, as much as possible, we intentionally adapted a slowed down approach to our work that was adaptable, giving ourselves grace and permission to be human. Second, we embedded room to get off track, which may sound antithetical to the goals of research, but in reality, we found that it facilitated deeper connections amongst team members and gave us the freedom and opportunity to see creative ideas and possibilities. But I want to acknowledge that co-production is not easy. It is an uphill battle. It is exhausting to try to work equitably in a hierarchical system, and I'm not going to pretend that it isn't. We espouse things that we expect to possess: patient-centeredness, strong communication skills, the ability to really listen. But then we are expected to practice these things in an environment that says, get this done as soon as possible. There's little in the way of structural support for the values that we are supposed to possess. And although there is no simple how-to guide or checklist on how to do co-production in a system that largely isn't built for it, there are paths forward. By approaching this work with a recognition that we will never have all of the answers and an ongoing commitment to learning, power sharing, and accountability, we can actualize a more equitable and inclusive future in which people with diverse perspectives have equal seats and equitable voices at the table. We invite you to start where you are. Start by asking questions. Start by reflecting on what co-production could look like in the context of your work. What would the benefits be? What challenges would you face? How would you navigate these? We hope that through this presentation, we have convinced you that co-production and inclusive leadership are worthwhile endeavors and given you some ideas of where to start. We want to thank you for learning about our journey and our work. We are proud of what we have produced, but we are equally proud of who we were and who we were to one another while doing the work. Thank you.
Wonderful. I don't know if this mic's on. Yes, it is. Thank you so much. It was fabulous. Do we have time for a couple of questions? Okay, so questions from the audience. Oh, I see a hand over here. Can somebody get a microphone? There we go.
Hi, I'm curious about your article that you submitted to the New England Journal of Medicine. If you could think of like one highlight of that article, could you share it with us?
Oh my goodness, one highlight. So this wasn't written in the article, so this is a bit of the juicy bits. Is that what you mean? Okay. So when we submitted the article, we didn't have any scenarios. We wrote the article, and the editor-in-chief said, well, you have to tell us what to do. You can't just say this. And so he asked us to create scenarios. But he didn't only ask us to create scenarios that we thought would be useful. He had a specific scenario that he wanted us to create. And it, you know where this is going, right? And the scenario that he wanted us to create was that you have two people that you're supervising, a man and a woman. And the man and the woman have children at the same time. But when the woman comes back from maternity leave, she's just not doing as well. And the man is advancing and she's not doing as well. And she's getting all the support that, the department can give her, but she's not doing as well. What do you do? And I can't tell you how many times we went back and forth on this because we didn't want to write it. Finally, we wrote it in a way that put the onus on the supervisor and asked the supervisor to consider reflective questions as to what they might not be doing to support her. So are there policies written? Have they been having mentorship meetings? Have they, have you talked about even, promotions, trajectories? And so we flipped the script so that we made it kind of, I knew why it was his responsibility to actually mentor somebody who was experienced, anybody. And I think we made it like with an elderly parent or any kind of leave. So we took the baby out. We were trying desperately to get the baby out of the picture. So, but that process was really interesting because I still think there's a lot of unconscious bias around the work that we're doing.
We have time for one more question.
What would you say is the biggest barrier to being able to effectively lead co-productively?
Yeah, I think that there's many barriers, but the mental health system typically works in a top-down fashion, whereby people with lived experience, things are done to and for them rather than with and by. And I think that when we operate in this way, we make assumptions about what people need, and we often miss the mark. I think people with lived experience they're the experts in their own experiences. They know their needs better than anyone else. And when coupled with professional perspectives, a richer and more comprehensive understanding emerges. And I think that through that, we can realize more equitable futures for our systems that are more responsive to the needs of the people who are most impacted. I think there's barriers such as funding to do this work, time to do this work. But I think that funding bodies, funders, and organizations, when presenting that they want to commit to co-production and highlighting diverse voices, need to take into account the time that doing things differently in a system that's not set up for it takes, the funding that we need to add to compensate people with lived experience for their time and expertise. So I think there's things that can be done at the ground up by bringing people together, but also structural things that can support this work to actualize more inclusive and equitable futures. Sophie, is there anything you want to add? Okay.
Well, thank you, Sophie and Holly. That was amazing. Thank you so much. And now I'd like to invite Megan Pilatzke up from Specialistern, did I pronounce that correctly? Canada. You're coming from Sudbury, I understand, and to speak about autistic women, underdiagnosed and misunderstood. Welcome.
Thank you. Thank you so much. This is my first conference in person. I'm so used to the pandemic being online. So it's really weird to have all these faces looking at me because I'm not used to it. I'm used to all the cameras turned off and everybody's maybe there. Okay. So thank you so much. Ian, really resonated with that last talk. I really think it deserves another round of applause because it was seriously amazing. And you know, as someone, I'm about to share my lived experience, being a part of co-design has been so meaningful. So anyway, I will go ahead and go forward once I get organized here. So conflict of interest, nothing very exciting. I'm from Specialist Turner Canada. I work freelance with the Israeli Neurodevelopmental Center here at CAMH, doing eco education. So the co-design, and I'm also a freelance public speaker. So no disclosures, no funding other than my role at CAMH. So introduction we already did, and I'm going to talk to you about how I got here. Why am I standing on the stage, and why should you listen to me? What autism is. I'm going to talk about autism in women, and where do we go from here? So how did I get here? Well, how did I get to this spot? And why am I talking to you? I'm not here as someone with a master's degree. I don't have a PhD, and I'm not here as a medical doctor or any type of healthcare professional. I'm here today as a person. In particular, I'm a woman with lived experience of autism, but I didn't always know I was autistic. It's actually only very recently that I found out about my autism. So you can see some photos of me, and my parents are watching along today, so they'll appreciate, I'm sure, they wanted to offer that support. Hi, Mom, Dad. So as a child, we kind of progresses here from left to right, right to the end. So as a child, I always knew that I was different. I didn't quite know how I was different, but I just had that instinct as a child that I was different from other children. You know, I was a pretty average student. Lived in a family. I had my parents, my brother, and otherwise had a pretty straightforward childhood. I was in sports. I played basketball for 10 years. I was a musician. I still am a musician. You know, did all these things that typical, quote unquote, typical kids do. But behind all of that, I did experience a lot of bullying as a child in school. At the time, I attributed it to moving within my city and going to a new school. New kid in school makes sense, right? But it was bigger than that. I knew that instinctively I was different from other kids and that I was being perceived differently and judged for that. But I didn't know how to really verbalize that because we're told all the time, right? We're growing up, we're going through things, and as we get older, we'll figure it out. Well, that didn't happen. I battled a lot of mental health issues, anxiety, panic attacks, depression. My first attempts to seek help were made on 2 occasions. I sought help with a family doctor that eventually retired, who dismissed it and ultimately said, "You're going through puberty and it's just hormones and you'll figure it out." The second one said, "Okay, you're depressed. Here's an SNRI and have a good day." And there was really nothing else ever done. There was no referral to a psychiatrist. There was nothing. And I kind of continued that way where I was really struggling. I was, you know, not able to get out of bed some days. I was going into, you know, spaces really overwhelmed and not really understanding why I was overwhelmed. I would go into a space today and be fine. And another day I'd go in and it'd be like, well, I don't know. You know, and once I got to university, I went to Laurentian and I got a Bachelor of Arts in Psychology. I missed a lot of classes and there were a lot of concerns about it. And I was told, you know, you should look into this more. And it's the fact of the matter it was, but I wasn't getting anywhere. So After that, this is my two cats. And for those of my cat lovers out there, for those that are wondering, the orange one is Oliver and the gray one is Abby, because everybody asks what their names are. So there it is. We know. So after university, I cycled through part-time jobs. I really like this photo, both because I'm with my cats, but also because in behind you can see a lot of items. I was actually moving through apartments. I moved through a lot in that part of my life. I cycled through part-time jobs. I really struggled with attendance. And eventually, though, I was hired full-time into a role in November of 2015 with the Government of Canada. I struggled with attendance due to my mental health. And even though I disclosed that, I was still treated differently. And I was discriminated against in that workplace. I still tried to seek help, but it was often just disregarded. And it took me going to a local telemedicine clinic and actually connecting with someone here down south, whose name I genuinely don't remember, where they finally said, hey, has anyone ever done any blood tests on you? No, not at all. Well, it'd be great if you did that. And ultimately, I was actually referred to CAMH. I came down here in the spring of 2016, and I saw a really awesome psychiatrist whose name I also don't remember. And if you're in this room, I'm sorry, but thank you. And thankfully, that was the first person that listened to me. And he put me on a wait list for a psychiatrist in Sudbury, which is where I'm from. And I saw my second psychiatrist in fall 2017. I was diagnosed with bipolar disorder type 2, and I was prescribed additional medications. But it really didn't ultimately improve anything, despite the SNRIs, despite lithium, despite, I was still struggling. And that second psychiatrist ended up discharging me in the summer of 2018. October of 2018 is a month I will never forget, because it was the month that I nearly took my own life. It was a horrible evening, and for some reason, I don't know why to this day, but I felt the need to go to the ER, and I did. And I faced more discrimination in the ER. I was told by a triage nurse, everybody has problems. Why can't you deal with it? Right? And I think it's pretty evident that up to this point, I was trying to deal with it, and it wasn't getting better. And I could have retreated. And the sad reality is I think a lot of people would retreat because they feel defeated. And to catch that point, they feel defeated to come there and they need help. We should not be dismissing someone like that. So what I did was I said, that's fine that you think that. If you want me removed, you can call the police. And that's what I did. So I stayed. I saw my third psychiatrist that evening, or no, following morning. That night, I heard a lot of talk from nurses and doctors alike saying, the crazy woman is in that room. That's the psych head. That's the psych case. I heard every single word. Remembering that I'm autistic, I hear everything very well. I eventually was diagnosed with treatment-resistant bipolar disorder, and I was offered transcranial magnetic stimulation, which I ultimately never ended up taking. My workplace struggles continued, and I was ultimately advised by my management team, despite really limited attempts at accommodation, that I should consider medical retirement. No other referrals were ever made, but I continued to try and seek help. But don't worry, things got better. In 2019 is when everything really changed. I met my husband. We got married last October. So there's my little thank you. And my husband was the first person to introduce me to autism. Our nephew, Hunter, is autistic. And at the time, I really knew nothing other than it's a word and it exists. And that's nice. It happens in kids, maybe boys. That's about it. And I really wanted to understand because our nephew is partially nonverbal. And I really wanted to know how to connect with him and how to build a relationship with him. And what ended up happening was I read a book, and that's the book in the middle there, Women and Girls with Autism Spectrum Disorder by Sarah Hendricks. That book I read in September of 2020, and I ended up in full tears because I knew in that moment, I said, oh, this is the answer. This is why nobody knows what's going on with me, because it's autism. And I immediately sought an autism assessment. It was $4,500 in Sudbury. However, thankfully, in Toronto, through the Red Path Center, I was able to access an assessment for $2,500. Still not much better, but it's still better than $4,000. And about 6 months later, I found out, yes, indeed, Megan, you are autistic. So that was May 2021, and we're getting on 3 years since then. And since then, I left my job. I work for Specialist Turner Canada, and I couldn't be more thrilled to work with my organization. It fuels my passion. And getting the opportunity to work with Dr. Pilatzke and others at CAMH has been so fulfilling for me to contribute my lived experience. And I even ended up publishing my very first peer-reviewed article this past February. Thank you. Now, I'm not here to talk about that article. It was just a review of all the research together. What I'm here to talk about is autism, because the reality is a lot of people don't know what autism is, and that's okay, because quite frankly, I didn't either. But why did it take me so long to find out about my autism? Well, it's important to understand that research is behind when it comes to autism. And as a result, our healthcare professionals are not properly educated on how to recognize autistic traits, never mind the general public. Now, autism is a lifelong neurodevelopmental disability. It's not something we acquire from vaccines. It doesn't come from bad parenting. It is something we are born with. It's a natural variation of the human brain. It is characterized by two main criteria, and the DSM-5 goes into more detail, but keeping it just high level here. The first is differences in social interaction and communication. So, for example, someone who is autistic may not understand or process nonverbal communication in the same way that a neurotypical or a neuromajority brain that functions in that way will. Then the second is difference in patterns of thought or behavior. So repetitive behaviors, a preference for routine and structure, etc. Autism is considered a spectrum. And you can see on that image there, we typically think of the autism spectrum as that linear, less autistic, really not autistic, to more autistic, very autistic, etc. But really and truly, it's a circle. It's very varied, rather, among autistic people. There really is no, one way to be autistic in any way, shape, or form. When we talk about autistic people, they're multifaceted. Like non-autistic people, we have strengths and challenges, just like anyone else. I want to emphasize it's not a mental health disorder, nor is it an intellectual disability. Certainly, these can co-occur, but it is not one of those things. And currently in Canada, according to the Public Health Agency of Canada's report on autism, based on the 2019 Canadian Health Survey published last year, year before now, 2022, we're in 2024, 1 in 50 are autistic. So where do women fit into all of this? Well, according to the DSM-5, states that the male to female ratio for autism, in other words, for 4 men that are diagnosed with autism, only 1 female is. Looms et al. 2017 states that the male to female ratio for autism is 3:1. And I argue that both of these statistics are completely flawed. Currently, autistic girls and women we know are under-recognized and diagnosed later than boys. Yet, when we look at these statistics, it really doesn't appear to be the case. Both are accurate statistics based on current diagnoses, but I argue that they're flawed for 2 main reasons. The first of these reasons is our limited understanding of autistic traits and how they present in women. When we started studying autism, we focused on studying white boys, sometimes white men. They were cisgender, or in other words, identified with their gender at birth, and identified typically as heterosexual. They were also often from Western cultures, and it allowed us to develop screening criteria that was ultimately, focused on that, these specific traits, and disregarded others. Furthermore, a 2021 study found a lower male to female ratio. In other words, they were more even among adults, which supports the limited research done on autism in adulthood and in girls and women. And in this study, the ratio was actually higher in childhood versus in adulthood. The second reason I consider these statistics flawed is because due to the limited understanding that we have of how autistic traits present in women, and in turn those screening criteria limitations, autistic women are going undiagnosed simply due to the fact that healthcare professionals don't have the necessary knowledge or understanding to recognize and assess for autism. Looms et al. Study further supports my reasoning in their study's conclusion by saying, quote, there appears to be a diagnostic gender bias, meaning that girls who meet criteria for autism are at a disproportionate risk of not receiving a clinical diagnosis. Prosterud et al.'s 2021 study that I previously referenced indicated in their discussion, quote, that several findings in our study indicated the presence of a gender bias in ASD diagnostic practice. So given both of those reasons, it's really hard for me to believe that they're accurate. Nonetheless, these statistics coupled with the DSM screening criteria have led to many stereotypes of autism in the media which still prevail today. Note that all of these representations on the screen, which many of us are familiar with, and I'm not saying they're not good shows, they are. They're white, they're cisgender, and they're heterosexual autistic men. And although autism can and certainly does present in this way, it's not a fair or full representation of autism. Furthermore, these stereotypes miseducate the public and healthcare providers further into believing that autism does not occur as often in women. And those stereotypes lead into this male-based lens of autism, leading to expectancy bias. However, sex and gender-related factors can modulate how autistic characteristics are expressed behaviorally and developmentally. We're going to hear that from Dr. Lee more tomorrow, Ming-Xuan. That was actually his study. In many cases, but not all, autistic women may learn to mask autistic traits. So masking involves suppressing or controlling behaviors to appear not autistic. So it includes things like rehearsing social situations. We're not talking about just rehearsing like a talk. I'm talking about like, today I rehearsed how I would meet you for the first time. I'm gesturing to one of my colleagues, and forced eye contact, scripted responses. And it takes a lot of cognitive energy, and it leads to anxiety often, panic attacks, depression, autistic burnout, suicidal ideations. And as a result, women are being diagnosed later or not at all because we're not seeing that. There are some additional barriers to assessment. I've met ultimately hundreds of women worldwide since receiving my diagnosis who are on a wait list, and they're self-identifying as autistic due to barriers in getting an assessment. Barriers such as long wait lists, things that are pretty familiar to all of us, lack of healthcare professionals assessing adults, most assess children, distance, fear of discrimination or not being believed, misdiagnosis, and cost, as I already referenced. So where do we go from here? I'm cognitive that I have about a minute left, so I'm going to wrap it up. I have met, as I said, I've met hundreds of women. So where do we go? Well, I finally found myself and began to thrive in my life, but too many women will never get this opportunity as it stands, an opportunity to live fulfilling lives as their autistic selves. But the good news is that change is slowly happening. This is Chloe Hayden, who is an autistic Australian woman. She's both a writer and an actress. And here she's portraying her role as Quinny, an autistic teenager in Netflix's Heartbreak High. And in my opinion, it's one of the most honest and true depictions of autism in women, with many of her scenes bringing me to tears simply due to the fact that the representation is so genuine. And ultimately, what do we need? While Chloe begins to diversify media representations of autism, more than ever, we need more research. We need research in women. We need research on 2S LGBTQIA+. By the way, 3 times more likely for autistic people to be, according to a University of Cambridge study. Different ethnicities, not just Western cultures, and different races. Of course, more funding and resources, and a national autism strategy, which was just approved. Bill S-203 went through the Senate, March 2023. We're still waiting on an autism strategy, but it's on its way. This is my last slide right now. So what can we do right now? Well, one of the things you're doing, which is so great because it's Autism Awareness Month in April, is you're learning more about autism right here, right now. Hire autistic speakers to come and speak. Well done, CAMH. Do that in your workplaces, do that everywhere. Connect with autistic creators on social media or read their books. And of course, I have to give a shout out to my organization. We're a not-for-profit that works with neurodivergent individuals and employers across Canada to further this work. So work with us, me and my team. I'd love to talk to you more about that. Neuro-inclusive hiring solutions. We do education like this live. We do it online. We do it in person. We do pre-recordings. We do e-learning. We do lots. Consultations. We can do look at your policies. We can tell you what those barriers are that Holly was referencing. And workplace support services, so job coaching. So thank you so much for this opportunity. If you want to connect with me, that's my email right there, or you can find me on LinkedIn. Thank you.
Thank you so much, Megan. Amazing talk. We have time for 2 questions. So does anyone have a question for Megan? I see one over here.
With social media, especially like TikTok, increasing awareness of autism and autism diagnosis, there's a lot of people discussing about how diagnoses are increasing and potentially that there's like a misdiagnosis of it. So I wonder what your opinion is on that, because obviously from the things we've discussed, it's usually hidden. So yeah.
Yeah, no, that's a really, really good question and one I get pretty often, as a matter of fact. There's a lot in the media going out right now, as well for ADHD. It's pretty prominent, especially in the United Kingdom right now, that there is this epidemic of autistic people. And there's this epidemic of people who are ADHD. What is happening? What are we doing wrong? You're not doing anything wrong. Here's what's going on. Research is advancing. And as a result, our DSM criteria is expanding. And so people like myself who were missed are now getting found. This is a good thing. This is an awesome thing. And there's those that will even say to me that, well, self-diagnosis, is that really valid? Yeah, it is. It is. You know, here's why the barriers, first and foremost, is why it's valid. But bigger than that, as it was already referenced even in the last talk, we know ourselves better than anyone else. We do a lot of research, whether it's TikTok, whether it's reading, we do the research. We know ourselves. So my response to that is, yes, it is increasing and it's a good thing. And that ultimately that's the reasoning behind it. And I'm hoping it continues to increase as time goes on.
And we have one more question right here, right here. Yep. Jordan.
Thank you. Thank you. Thank you so much for that talk. It was really awesome. And I just feel so for your journey. And that's made me really think about, there are important times for sex differences, but sometimes certain diseases get classified as more common in women than men, or more common in men than women. And the diagnostic criteria then become about the way that disease manifests itself in a given sex. So like the diagnostic criteria for autism may be more focused on male behaviors than female behaviors. And so I'm just wondering what your thoughts are about pushing forward the particular behaviors that might be really important to your diagnosis or other women's diagnosis of autism to make it more common for more women to be diagnosed when they are autistic.
That's right.
Rather than, this applies to other conditions, other neurodiversities as well, right? Like attention deficit disorders, et cetera. So
Yeah.
I'd love to hear your thoughts about that.
Yeah, it's a tricky one because I don't want to say that the DSM's criteria is fully wrong. It isn't. It's identified individuals, but the argument is simply that it's not diversified enough. And in some cases, I want to also emphasize that some of the criteria are written in there, but it's not elaborated onto how to recognize them. So those masking behaviors that I referenced, right, will mask things like eye contact, not making eye contact is a common thing that I'll go with in this case that autistic people struggle with. And if we are forcing ourselves like we do in interviews or in meeting new people, including doctors, including psychiatrists, including psychologists, everybody, then we're missing that. But having that, I believe the bigger awareness and perhaps maybe an appendices or some method of better identifying how traits can present is, I think, the way to go. Certainly, there might be traits that are only specific to women or only specific to men, but I don't know if there's enough research to say specifically as to who falls into what. So for now, while there's that limited research, I would say that we need to keep it broad, keep it open, but we need to have that interpretation, which I know the DSM did in 2013 when we modified and put, for example, Asperger's syndrome is now under the umbrella of autism. We did do that, and that's kind of the change in this whole revolution, if you will, of autistic people suddenly being found. But there's certainly more we can do, and I agree that that was a good point on that. Great. Thank you so much.
Thank you so much, Megan. That was amazing. And now our next speaker is Patricia Tomasi from the Canadian Perinatal Mental Health Collaborative, coming from Calgary. Thank you so much. Speaking about why Canada needs a perinatal mental health strategy.
Thank you. I'm not from Calgary, but I love Calgary. I was just there not too long ago from Toronto. I'm so privileged and honored to be here. Thank you so much for inviting me to speak. I'm also tremendously nervous, but I should eat more pasta, right, Benicio? I learned a lot this morning. My dad always said, you don't need medication, you need another plate of fettuccine. So maybe he was right. But I'm good. I'm in my follicular phase. I got my compression socks on. So I think might do well here today. Though I am 47, Julia, so I'm worried because I'm right in that perimenopausal and visceral fat stage and all that. So I don't know how it's gonna go. It's hot in here. Okay, let's start. So you're too kind. So why Canada needs a perinatal mental health strategy? First of all, who the heck am I and why should you care about that? The Canadian Perinatal Mental Health Collaborative, or CPMHC for short, is what I'll go by from now forward. We started this about 5 years ago. We're in our 5th year, and I say we, it's myself and co-founder Jamie Charlebois, who is at Waypoint Mental Health Hospital now in a director role. Very excited for her, but she left me, so I'm very sad. But we started this, we were called Two Barrie Moms on a Mission. Actually, that's where I'm from, Barrie. And we started this and we collected we're like, oh my God, we can't do this on our own. We both had lived experience and we wanted to improve perinatal mental health care in Canada. My background was journalism and communications. Jamie was the first perinatal mood and disorder coordinator in North Simcoe, Muskoka. So she had all that wonderful clinical experience, but we knew we needed everybody to come together to make this happen in Canada. So we formed a national committee. Dr. Galea was actually one of our first to join our national committee, and we had Dr. Simone Bigot. We recognized amazing researchers like Dr. Daisy Singla. And so we knew we needed to get everybody together to do this. So our mission is to improve and advance perinatal mental health care in Canada. And our vision is that all individuals and families are able to access the services they need to experience a mentally healthy perinatal period. Our goal is that by 2032, federal, provincial, and territorial governments will have passed and implemented appropriately funded policies and legislation that are providing people timely access to perinatal mental health services, thereby substantially reducing perinatal mental illness in Canada. So why do we think Canada needs a national strategy? Because we believe sound perinatal mental health improves the well-being of all Canadians. Every Canadian that needs it should have equal and timely access to perinatal mental health services. And we believe, maybe not everybody holds this view, but we believe that a strategic, well-organized and thoughtful plan led by the federal government involving multiple partners and stakeholders is the only way to bring about meaningful, lasting policy and systemic change. And so that includes researchers, obviously. Quickly, what is perinatal mental health? I'm sure most of you in this room know, but just a quick review. Perinatal refers to the time period between conception to 1 year postpartum, and I like to say and beyond. What is perinatal mental health? Perinatal mental health is when a perinatal person and their family are able to experience the stage of life in a state of overall well-being. That is part of a response. It's actually longer that I got from Dr. Bigot in our anthology of perinatal mental health stories of women across Canada. Thought that was such a fantastic definition. Perinatal mental illness can include depression, anxiety, bipolar, and psychosis. It can happen due to physical, social, genetic, and psychological changes. Of 400,000 births in Canada each year, 1 in 5 or 20%. I know you saw 15 before. Yes, it can range. I think it's underreported, but 20% of postpartum individuals experience mental illness, which means 80,000 families are affected annually. And suicide is the 4th leading cause of maternal death in Canada, with 1 in 19 deaths in Ontario attributable to suicide. So without timely access to treatment, infants are at a higher risk of mental health illness as adults, perpetuating this cycle of mental illness and contributing to the $50 billion annual economic cost of mental illness to Canadians. So what's the problem here? We know all about perinatal mental health, perinatal mental illness. So what's going on? Why are we here? Why am I spending all my time, 12 to 16 hours a day, advocating for this while I still have a full-time job on the side, doing this all volunteer? Why? Why the heck am I doing this? Oops. Oh, the percentages have a mind of their own, but they are accurate. So we did a research study with our principal investigator, Dr. Leanne Tomfor-Matson, out of the University of Calgary. Well, it was Calgary theme. And we found that 57% of healthcare providers surveyed said they don't have specialized perinatal mental health training. 87% say they don't have mandated perinatal mental health screening at their workplace. A whopping 95% of healthcare providers believe that perinatal mental health services are inefficient in Canada. 87% say that persons from diverse backgrounds encounter language, cultural, and cost barriers to perinatal mental health services. And 2/3 of patients with perinatal depression do not receive treatment. Research is super important, but as the advocate, the national advocate for perinatal mental health, we like to put faces to the data and the stats. So here are some of the women that we work with. These are just some. There are thousands more that we hear from all the time about trying to access services. Women like Carly Weldon from Windsor, who says, I needed medical help and ended up going to the emergency room a total of 3 times to try and find it. I felt like I had to justify why I was feeling the way that I was. Dr. Anita Ewan from Toronto says, I know particularly as a Black teenage mother, I was uncomfortable calling the police or emergency services to help me through the negative thoughts. Candace Thomas from Barrie, Ontario. She says, thoughts of not being here anymore creep up, and some days I don't have the energy to fight them. I'm terrified. Who can help me? Stephanie George from Jarvis, Ontario. My story is not unique. Many Indigenous women suffer from postpartum mood and anxiety disorders, but in our communities, there is a greater stigma towards mental illness. Sarah Cunningham from Bowmanville. The doctor placed me on a 4-month wait list to see a general psychiatrist. I was crushed. And Lindsay Garreau from Regina. I was not screened. I had postpartum depression with my previous baby, so I thought it would be on my file somewhere that I struggled. I also try and tell my story as often as I can. You can read probably the most open I've ever been about my story in this month's edition of Toronto Life. Thankfully, my husband is a big supporter and willingly supports and contributes to stories, and any time that I get asked to tell my story. I myself suffered from postpartum psychosis twice, and was able to get help the second time only because I had educated myself and done the research and went to the emergency room, was sent home despite my saying, no, I think I need to be here, and went to see my doctor the next day, asked her to run me through the Edinburgh postnatal depression scale, told her I wasn't going to score high. It was mostly anxiety. I was slipping in and out of reality. I knew that the postpartum psychosis was very close. asked her for medication, went on medication, and then started to feel better. I consider myself lucky to be here because of what I went through, particularly the first time I experienced postpartum psychosis. And I think our stories are really important to tell along with the data. And when I always talk to researchers and scientists and always say, if there are participants that are willing to tell their stories, that's a great way to get buy-in and also just have that human connection with politicians that you're trying to get their ear on. It's stories that they love. It's stories that really help them understand the issue, but the data is really important too. So this next video I'm going to show you right on time. This is great. Sounds like 10 minutes right here. Is this next story is the story of Flora Babakani as told by her sister Mimi, our most impactful story.
But as far as I know, she was never prompted or assessed in any way in terms of her mental health. Yeah, I believe that she was really struggling mentally before the pregnancy. And Flora was so happy. She was ecstatic. She was like showing us Amber, just telling us how amazing she felt. And she couldn't believe she had a healthy, beautiful baby girl. She was just like cloud nine, top of the world, just really, really happy. Her lifelong dream was always to have a baby. She called me 3 days later and she was still in the hospital and she was like hysterical, like absolutely hysterical, really upset, really angry. She definitely wasn't diagnosed. She definitely wasn't taking medication. But Flora never really, she never really expressed at that time that she was feeling really upset in any way. The only indication that we had was that she was quite disconnected from the baby. They managed to speak to a doctor by Thursday, and the doctor said that they were going to give Flora a call on Monday. And then Flora passed away on the Friday. So it's so close to getting help. I remember saying those words and she was like, I promise everything's okay. And she was like, I love you so much. And I was like, I love you too. And that was the last I ever spoke to her. Yeah, I don't think it was a proper assessment of any kind. And I'm shocked as well because when she did call me from the hospital 3 days later and she was hysterical, and surrounded by doctors and nurses. I just thought, well, everybody's assessing her physical health. Like, why aren't they checking on her mental health, you know?
Yeah.
That should be part of it. Laura would be so proud and happy to raise this awareness for other people. Because she was that type of person as well, and she would have loved she would love that you are doing this in her honor.
I first heard about Flora through a friend of mine that I went to university with, who knew Flora's sister, who knows Flora's sister. And I got a phone call one day and she told me the story about Flora and that her sister Mimi wanted to tell her story. That's how we found out about Flora. This is not something that's captured in statistics. The SOGC, Society of Obstetricians and Gynecologists of Canada, are trying to change that. Deaths attributed to perinatal mental illness. And so we hear about these stories through word of mouth. There have been more Floras since 2022, and they participate in Flora's Walk. We do an annual walk now called Flora's Walk in her memory, in her honor, and also to raise more awareness for perinatal mental illness. As Flora's story is an example of the worst possible outcome for perinatal mental illness, a death, a tragedy that we believe could have been prevented and avoided. This is our third annual walk happening just shortly in May. There are 50 walks happening across Canada. Since 2022, we've raised over $275,000 for 100 organizations across Canada. The Flora's Walk, we do a fundraiser and then we give the money, we give 75% of the money back to community organizations to help them bolster their perinatal mental health programs in their community. In Ottawa on May 1st, we will be there on Parliament Hill with Minister of Mental Health and Addictions, the Honorable Yara Sachs, and MPs Pam DeMoth, Karen Vecchio, Don Davies, Heather McPherson, Elizabeth May. They'll all be speaking there. Everyone is welcome to attend. I can give you a link for the free ticket if you'd like to attend on May 1st, and then we will walk to the Centennial Flame, place flowers there, and have a moment of silence for Flora. So how we also advocate is through collaborations with many researchers in this room. We've done over 100 letters of support for different research projects, and we're involved in many exciting research moving this issue forward, such as with Brain Canada, with Dr. Lisa Galea, with Dr. Simone Vigaud and Dr. Benicio Fry working on the CAMH clinical guidelines for perinatal mental health, the very first time this is happening, which is a tremendously exciting work. We're a stakeholder with Dr. Daisy Singla on the Summit trial, which is revolutionary. We're part of the Women's Health Research Cluster, and we have had support, and we have support from Green Shield and Daymark Foundation, and we're just so grateful to have these collaborations and partnerships. And we do a lot of government relations as well. We were able to get on the mandate letter for the Minister of Mental Health and Addictions in 2021, calling for timely access to perinatal mental health services. And we're starting chapters across Canada, thanks to help from Green Shield, who are here today. So thank you. Working at the provincial territorial level as well as the federal level. So we've done amazing work and we're so proud of ourselves. But like I said, it's hard. A statistic just came out that, 80% of people that work in nonprofits are women, and a lot of them are, BIPOC and 2S LGBTQIA, and we're overworked and underpaid. For us, we're all volunteer. I do this completely off the side of my desk, as many of our volunteers do. Still have a full-time job on the side. Burnout is near and real. We're trying to keep pace with momentum. It's been a hard winter. We almost didn't make it, but we know that the voice of lived experience is really important and that we need to stay here. And I'm passionate about this work. So yes, this is my unabashed plea for anyone that wants to partner with us to help us gain that sustainable funding. I'm here. I'm eager to talk to you because I think our voices are vital. Thank you.
Thank you so much, Patricia. Do we have questions? We have time for 2 questions. Around. I'm sure there must be a question. Lisa.
Yeah, pasta's on the menu always.
Okay.
Thank you very much, Patricia. That was moving as always. You got me a little teared up there. Currently, is there no national perinatal mental health strategy in Canada? Is that not any part of the official guidelines in Canada?
No, we do not have a national strategy, unlike the US, the UK, and Australia. The closest that we will come is having the CAMH guideline, clinical guidelines published in the fall. But it's then implementing all of those wonderful recommendations and guidelines that the work that needs to be done.
Do we have another question? Looking around. Okay, well, we'll move on. Thank you so much,
you.
Patricia. And we have Marisa Blake, a researcher from Ottawa coming up. Marisa, I hope you're approaching the stage to talk about Indigenous women, Two-Spirit, trans and gender diverse people's experiences with anti-Indigenous racism and mental health care. Welcome, and we look forward to your talk.
Hey everyone, my name is Marisa. My pronouns are she, her. My presentation is Indigenous women, Two-Spirit, trans, and gender diverse people's experience with anti-Indigenous racism and mental health care. So I'm honored to be here today on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and Wendat peoples. I currently reside on the unceded and traditional territories of the Anishinaabe Algonquin in Ottawa. Originally, I'm from Northern Ontario within Treaty 9 territory. I have mixed ancestry of white settler and Ojibwe descent. My educational background is in nutrition sciences from the University of Guelph. Following my education, I spent 7 years in medical clinics working closely with physicians and including developing and leading my own nutrition counseling program tailored for patients managing diabetes and high cholesterol. In my most recent role as a senior project officer on the health policy and research team at the Native Women's Association of Canada, I had the privilege of leading several community-based research projects focused on cannabis and health. And I'm currently a community-based research with cannabis and health as a research coordinator at McMaster University. I hope that it can help add context to these issues by sharing my perspectives from working with a community-based research with Indigenous communities across Turtle Island and Inuit Nungat. I will cover Indigenous perspectives, historical context, current issues, and recommendations for healthcare professionals. These are difficult topics, and I appreciate that you're here to listen today, but please prioritize your well-being, and if you need to step out, please do. I'd like to give an overview of what health and well-being could be defined as through an Indigenous perspectives, keeping in mind that Indigenous people don't all have the same cultural practices or perspectives and come from diverse backgrounds and distinct groups. Health and well-being has a different meaning from an Indigenous perspective than that of the Western perspectives. Well-being or wellness is multifaceted, interconnected, and incorporates physical, spiritual, mental, and emotional health. Physical wellness refers to the body, its functions, its resilience against illness and disease. Mental wellness encompasses psychological functions, including positive sense of self, effective coping strategies, and the ability to function well within the community. Emotional wellness relates to the ability to recognize, express, and manage our emotions in healthy and constructive ways. Spiritual wellness pertains to our sense of meaning, purpose, a connection to the land and ancestors, and all dimensions of wellness are necessary. The medicine wheel is a tool used by some to ensure the overarching well-being of an individual and allows Indigenous peoples to care for themselves and others. Indigenous wellness models emphasize the connection to community and the role that connectivity to others play. Indigenous people view personhood and health as not existing within itself, but as something that depends on the relationships with others around us, including the land and nature. Identity is a core attribute of many Indigenous cultures and an essential element of spiritual wellness derived from language, land, and ancestry. Land and culture-based practices are essential to empowering personal health care and maintaining strong cultural identities. What Western perspectives lack is community care or community actualization understanding, which means being a good ancestor, being a good relative. Community care and community love is seen as the highest forms of well-being, as opposed to Western perspectives, which value individuals' forms of wellness and love. Western or allopathic medicine may examine mental health disorders such as addiction and post-traumatic stress in a mechanical point of view, whereas Indigenous ways of knowing may see mental health issues as symptomatic of spiritual injury. Further, much of the current research on mental health and Indigenous peoples emphasizes the risk of suicide, alcohol, and substance use. To date, urban, off-reserve, First Nations, and Métis populations in particular are dramatically underrepresented in health research. And additionally, ways of evaluating mental health in the current Canadian health system differs from that of traditional Indigenous knowledges and ways of assessing wellness. So not only were land and resources targeted, but the imposition of European forms of gender and sexuality were central to the overall project of colonization in Canada. Christian white settler values imposed a binary view on Indigenous people's gender expressions and community roles. Violence was enforced through the Indian Act, residential schools, the 60 Scoop, Indian agents, and forced relocation to reserved lands. Social norms vary greatly between Indigenous groups, but a common thread throughout these nations was the lack of strict division of people into the binary of men and women based on biology. No single system of morality could condemn same-sex and same-gender relationships, and these things only appeared later with Christianity and colonialism. So there's over 200 terms to describe gender fluidity across Turtle Island and Inuit Nunavut. The term two-spirit was first recognized in 1990 as an umbrella term that can be used to help bridge the gap between Western and Indigenous ways of understanding gender and sexual identities. Two-spirit, it describes someone who has both a masculine and feminine spirit, and it may also encompass gender identity, sexual identity, and spiritual identities. In Western culture, we might use terms such as gay, lesbian, bisexual, transgender, gender fluid, or who have multiple gender identities. Although two-spirit can be considered a pan-Indigenous term, each specific culture may have their own unique understandings and ways of speaking about sex and gender that are grounded in spiritual beliefs. Inuit gender is traditionally fluid and does not neatly fit into a binary framework. While complementary gender roles existed traditionally, the extent to which they are based on biological sex remains unclear. Community roles allow people to transgress gender categories, swap roles, and assume a mixture of responsibilities. In Métis culture, two-spirit were often understood to embody both masculine and feminine energies and perspectives. They often acted as mediators, and in this role, they would assist by facilitating effective communication between men and women. Two-spirit also held important community roles such as child rearers and healers. So by taking a static binary gender category as a given, the nuance of traditional forms of gender expression and sexuality is erased, perpetuating the notion that queerness is not part of our Indigenous cultures, which has negative impact on 2S LGBTQI plus identifying Indigenous folks. This is a quote by Brandon Fenton. Indigenous people are likely to have experienced multiple and overlapping cataclysmic traumas, starting historically with settler missionaries attempting to force religious conversion, as well as war and community massacres, followed by the creation and segregation onto reserved lands. The state's broken treaty promises, attempts at forced assimilation, and the outlawing of cultural ceremonies. To the more recent state-mandated residential schools and forced adoption programs that tore Indigenous families apart. The impact of colonization on Indigenous peoples can be understood using this model. The triangle is composed of 3 parts: eugenics, genocide, and intergenerational trauma. Its purpose is to see the larger picture and interconnectedness of these systems. Eugenics is placed at the bottom as a reminder that this is the belief system that forms the root. Eugenics ideology was present at the formation of Canada, where it was used as a means to justify assimilationist policies toward Indigenous peoples during the country's early settlement. This ideology gained traction in the early 20th century, leading to the implementation of policies such as the Sexual Sterilization Act of Alberta in 1928 and the Eugenics Board of British Columbia 1933 to 1972, which facilitated the involuntary sterilization of thousands of individuals deemed unfit by society, including those with disabilities, mental illness, and in the Indigenous peoples. In 1946, the term genocide was created by the UN in response to both the Holocaust and other historical events. According to the United Nations Article 2 of the Convention, a genocide can be defined as any of the following acts committed with intent to destroy, in whole or in part, a national, ethnic, racial, or religious group, such as killing members of a group, causing serious bodily or mental harm to members of the group, deliberately inflicting on the group conditions of life calculated to bring about its physical destruction in whole or in part, imposing measures intended to prevent births within the group, and forcibly transferring children from the group to another group. The cumulative and ongoing effects of intergenerational trauma have resulted in consistent health and socioeconomic disparities between Indigenous and non-Indigenous peoples. The intergenerational trauma caused by the legacy of residential schools is also associated with a higher risk of substance abuse. As a continuation of the practice of eugenics, legislation was enacted that largely targeted Indigenous women. Coerced sterilization of Indigenous women took place both within and outside existing legislation and in federally operated Indian hospitals. Many of these forced procedures occurred during C-sections, routine surgeries, and coercive tubal ligations. While the supportive policies that promoted sterilization stopped in 1972 and 1973, and although they clearly violate medical ethics, the forced or coerced sterilization of Indigenous women is not explicitly illegal in Canada. Data indicate that between 1970 and 1975, 1,200 Indigenous women were sterilized in Canada. Between 2015 and 2019, over 100 Indigenous women have come forward to say that they were forced or coerced to undergo a sterilization procedure in Canada. Shame, guilt, and fear prevent many more Indigenous women from sharing their stories. To many Indigenous women, their identity as life givers are sacred, and to have the ability taken away leads to immeasurable physical, emotional, mental, and spiritual pain. The practice of birth alerts and removal of Indigenous women from their communities to give birth in Western hospitals are more recent examples of how colonial policy undermines Indigenous reproductive practices. Policies such as the Indian Act have sexualized and devalued women, two-spirit, trans, and gender diverse peoples, making them more likely to be subject to systemic and individually perpetuated violence within and outside of their communities. The term MMI-WG2S+ is used to describe the rates at which Indigenous women and two-spirit peoples go missing, are murdered, and/or experience other forms of violence by non-Indigenous people. An example of MMI-WG2S+ would be when an Indigenous woman is traveling for healthcare and is kidnapped during these travels. Other examples can be seen when an Indigenous person goes missing and law enforcement does not do everything they can to find this person. All of these events, including MMI-WG2S+, contribute to very specific healthcare barriers and disparities. Colonial violence, as well as racism, sexism, homophobia, and transphobia against Indigenous women and two-spirit peoples has become embedded in everyday life, including through institutions like the healthcare system. Indigenous peoples have every right to fear seeking healthcare for risks of discrimination and racism and re-traumatization. Further, the needs are not being met due to lack of access to basic care and services, or only receiving transient access to providers. There's an urgent need for changes in healthcare practice, structures, and policy development to address these disparities. Forms of violence in the healthcare system can be seen when staff make assumptions based on stereotypes, have dismissive attitudes and judgmental behaviors. Providers do not take time to ask relevant questions or examine the patient, assuming the issue is related to alcohol use, addiction, or sexual deviance. Making assumptions that all Indigenous peoples are the same and have the same healthcare needs, and many Indigenous peoples cope by not disclosing their Indigenous identity or avoid seeking help altogether. This results in poor health outcomes for Indigenous peoples, including negligent care that leads to death, long-term healthcare and reproductive concerns going unaddressed, leading to more severe health issues, lack of trust of Indigenous people toward health service care providers, and fears of stigmatization for substance use issues. This is also apparent in higher rates of type 2 diabetes, heart disease, and high cholesterol, and malnutrition for Indigenous people. Taking a decolonized approach to healthcare means a more holistic approach. Indigenous methods in medicine are not contrary to biomedicine, but complementary. A Tuatmunk, or two-eyed seeing, is a Mi'kmaq method introduced by Mi'kmaq grandmother Merdina and Albert Marshall. Two-eyed seeing is used as an approach, ethical protocol, or guiding principle. Since Indigenous ways of knowing are hard to define, Western methodologies can work alongside Indigenous ways of knowing and knowledge production. The methodology stresses the importance of viewing the world through one eye, using the strengths of Indigenous worldviews, with the other eye, the strengths of Western worldviews, to see together with both eyes that benefit all. Numerous studies have shown that two-eyed seeing is a great way to support the healing journey. Two-eyed seeing ensures that those who are doing research, providing training or support, are accountable to those they're working with, and carefully including grandmothers in the process. Commonly, programs and services lack Indigenous input and forget how all aspects of Indigenous well-being need to be integrated into programs and policies. Taking an Indigenous approach looks like rooting healing in Indigenous values and traditions, asking Indigenous people what they want and need, legitimizing and incorporating Indigenous ways of knowing, such as storytelling, oral history. Regardless of scientific validation, integrating holistic methods of well-being serves to provide unseen benefits on the emotional, mental, physical, and spiritual forms of health for all, and may also benefit non-Indigenous patients and clients. Before I wrap up, here's a few tangible recommendations. To address discrimination and racism in healthcare, practices must be aligned with the calls of action from the Truth and Reconciliation Commission of Canada and the United Nations Declaration on the Rights of Indigenous Peoples. Recommendations for improving quality of care and access for Indigenous people include enhancing cultural sensitivity training for healthcare providers, increasing Indigenous representation in healthcare leadership and policymaking, and addressing systemic issues such as funding shortages and recruitment challenges. Meeting the need for culturally safe health teaching and promotion includes providing information on nutrition, health practices, and preventative care tailored to Indigenous cultural contexts. Professionals must learn and acknowledge the historical and ongoing effects of colonization on Indigenous peoples and understand the current socio-political circumstances of the communities they serve. We must acknowledge the complexity and nuance of gender expression and sexuality of Indigenous peoples. Avoid assumptions and critically reflect on your personal biases and understand that the individuals have unique needs. Build trust with Indigenous communities by creating safe and inclusive spaces for all. Lead with positivity instead of a deficit-based approach, and avoiding leading with substance use or other sensitive questioning. Use inclusive and accessible language. Take a non-judgmental and harm reduction approach. Be a leader in practicing culturally safe care with two-eyed seeing in mind and incorporating Indigenous symbols or art into healthcare settings. Indigenous service users reported positive encounters with providers when they feel listened to, respected, and supported. Access to dependable information and culturally sensitive care positively influence their experiences. Thank you, Miigwech.
Marisa, thank you so much. What an excellent talk and so powerful. Really appreciate such an important area, and really appreciate your presentation. Do we have time for 2 questions? We do. Do we have people from the audience who have some questions to ask of Marisa? Yes. A question. Yep.
Is this on? Okay. Check. Thanks so much for this presentation. Really resonated as someone who is, I am as white as they come, but my mother-in-law is an Pasquaya Cree who was a victim of the 60 scoop. And so for me, this is a very powerful and important topic that is often not talked about enough. What my question is you've given a lot of tangible recommendations that I think really impact everybody. But as individuals who are in the community, what can we each do you think, that would help to promote, I don't know a good word to describe, I'm without words, but essentially to make it more inclusive and more, I think we know what I'm trying to ask, if that makes sense. Sorry.
Yeah, good question. So I think that's, keeping in mind increasing community care and improving the community around us, being active with everyone around us, or know your neighbors, just playing a supportive role within your community goes a long way. Showing up for others, and specifically like taking time to learn about Indigenous issues, and taking personal responsibility over educating yourself without placing the burden on Indigenous folks to have to teach you that. Just taking that initiative yourself really goes a long way to being a good ally.
Thank you. And another question. Okay, I see you first. Sorry. Okay. We might have time for 2 more, but there we go. Can you go there?
Hi, thank you so much for that. So informative. The practice of forced sterilization, I saw the shock in the room when you shared that this is something that's still happening. And I'm wondering if you have any ideas on what can specifically be done to eliminate that practice.
I think it starts with training in like healthcare providers, professionals training. Including Indigenous cultural information, learning how to best support Indigenous folks, and, allowing them to have control over their own bodies without making decisions for them and taking away their decisions. And I think that as well, like just teaching about any kinds of medical treatments, like for example, with some of the forced tubal ligations, some of the patients were under the assumption or under the impression that they were reversible procedures, as they were told by their healthcare providers, and then later found out that that's not the case. So that goes with educating and having that prior informed consent. Within hospitals as well, like Indigenous liaisons can work as advocates and help that continuity of care and make sure that they're supported throughout everything.
Thanks for sharing it.
So thank you so much. And I've been told, I'm sorry, do we, oh, what? Oh, okay, sorry. Okay, so we can squeeze in a really fast question.
Sure,
Really
sure.
fast.
Really question. Such a great presentation. Thanks so much for sharing it. If there's one thing that you could think that employers should be doing to add to their programming when it comes to Indigenous wellness strategies, what would that one thing be?
Like employers of like healthcare?
Businesses, like we work at a bank, Bank of Montreal here. Any employer.
I mean, I think placing the same value for Indigenous cultural knowledge, Indigenous language knowledge as we do on, say, like, French as an asset, as a second language. Like if someone had an Indigenous language, it should be treated as an asset as well. Fair and equitable pay, enforcing wage transparency, and flexibility for staff. Many Indigenous women are in the caregiver role, so if they're not supported, then they're not going to succeed at their work.
Okay. Well, thank you so much. I think a huge round of applause is needed for all of the panelists. They were amazing. And I want to just say thank you for your stories, for your, generous time and your incredible insights. All of you, just an incredible panel. Thank you so much.